Okay, we're good to go, Sarah.
Great, thank you. So welcome to the Justice and Mental Health Collaboration Program Data and Information Sharing Learning Community. This session is focusing on building your own Cascade. So based on the presentation that we had last time, which was a little bit about what the Cascade model is, we asked you to do an exercise to start thinking through this, and we're lucky enough to be joined by our partner in this, Dr. Faye Taxman, as well as Margaret Cawood from Georgia Juvenile Justice. So we'll do some brief welcomes and introductions. Then we're going to go through and review the exercise that you all submitted from last session. So thank you so much for taking the time to do that. For those of you who were able to, some really good and interesting information. Then there will be a brief overview, somewhat of a refresher, and a bit of new information on the Cascade. And then we're going to hear about how they use the Cascade in Georgia's juvenile justice system. And then we're going to talk a little bit more about how you can use this model to build out the data collection and quality assurance processes in your justice and mental health collaboration program. So for the speakers today, we have Margaret Cawood. She's the Deputy Commissioner of the Georgia Department of Juvenile Justice. She also has been a part of the Juvenile Justice Trials Network, which she'll describe, which helped her work through this Cascade model at Georgia's Department of Juvenile Justice. You know Faye Taxman, who has been on our other webinars, so happy to have her back today to share more information with you all. I'm Sarah Warsberg. I'm a program director here at the Council of State Governments Justice Center. I oversee the training and technical assistance for the Justice and Mental Health Collaboration Program. I will mention that my colleague Sheila Tillman is on the line, but a lot of us East Coasters have had power outage issues, so we weren't sure what her situation would look like today. So she is on the line, but not able to facilitate. She'll still continue to lead the learning community moving forward. So as you know, we've got this 2 tracks to this learning community. You're in the project coordinators track, and you all applied, and we're excited to continue working with you, and really glad that people are able to turn on their cameras today. If you have any questions as we go, you can also feel free to use the chat box. We'll be monitoring that to make sure we get all of your questions answered. This is supposed to be discussion oriented, so please feel free to jump in with questions at any time. We welcome that. So just a reminder, these are your colleagues. We have 12 different states represented on this call, and lots of programs across the justice system that deal with mental illness and co-occurring substance use disorder. So as we're going, we hope you get to know each other more, and if you ever want to connect with any of your colleagues from the other programs, please let us know, and we're happy to help facilitate those connections either through Sheila or through your TA coach. So the next 2 sessions are actually in October and December, so we'll have some time in between, which will give more time for the next exercise as well. So session 3 is right now scheduled for October 8th, and it's on how to structure an evaluation design. So really thinking about your role as project coordinators in partnering with the researchers to help make sure you're getting the information you need from that partnership. Then session 4 will be in early December, and it's going to be an overview of implementation science. So really the backbone to all of this for all of these projects is we have these planning phases to our grants, and then the rubber hits the road when you start implementing, and things change rapidly as we move towards implementation. So really thinking about how to use implementation science for quality assurance purposes, for fidelity to evidence-based practices, and really to build the foundation that will lead to sustainability for your programs. So I'm going to pass it over to Faye Taxman to talk about the results from the different exercises. Take it away, Faye.
All right. Well, thank you, everyone. Welcome, and I'm glad we're all here today. I'm one of those people that Sarah referred to that has internet issues, so forgive me for if it's all a bit wonky here. So I wanted to start off at the end of our last session, which was in at the end of May, beginning of June. We had everyone do an exercise where we asked you to talk about what kind of steps you've taken. Oh, not ready to move yet. What kind of steps you've taken to screen and assess clients in your system, what tools people use, and then how to define the population in need. So I want to stress that this is an important step to building your cascade, which is why we wanted to sort of begin at this place. Next slide. You know, essentially, of the 19 grantees that are part of this learning community, we come from different walks of the justice system. Some are focused on mental illness in jails. Others are focused on training opportunities for law enforcement. Others are focused on mental health courts, jail programs, reentry programs. But collectively, you know, and one principle in our field is using a valid screening and assessment tool to figure out what is really the needs of the clients in the system. Next slide, please. So we wanted to start off by asking people, what steps have you taken to screen and assess people in your system? And as we expected and as we found out, many of the grantees had really already began the process of implementing screening and assessment procedures throughout the spectrum of the justice system, and to really try to integrate more mental health screening during different processes of the justice system. Of course, this is important because without these valid screening tools, we're not really able to see what kind of needs clients have so that we can do that triage or referring people to the appropriate place. Next item. So these are just a sample of some of the tools that people use. You know, you could see that amongst the 19 of us here, that there's a wide variety of tools. I wonder if anyone's interested in just telling us about their experience with the tools themselves. Do they find that staff you know, find the information useful? Do they use that? Do you use it in terms of thinking about who needs to go to what kind of program and service? You know, so as Sarah said, we are really trying to encourage discussion and participation. So anyone want to talk about their tools and how they're used in their system? Alternatively, I can pick on someone if anyone doesn't want to volunteer.
Hi, this is Melissa McRoby-Tolf. Can you hear me?
Yes.
From Warsberg, Douglas County, Oregon. And we've been using, we just completed a data gathering exercise where we used the brief jail mental health screen at booking for almost a year, just as a data gathering tool. And we didn't, it was de-identified. And so we just did that to determine we have about 34% of people being booked into the Douglas County Jail were flagged as possibly having a serious mental illness. Unfortunately, we don't have the capacity to do follow-up assessments in jail right now, and so it was just a data gathering exercise. But one of the things we ran into was that deputies were sort of incompletely filling out the form, we also, for our own purposes, added some demographic information for our data gathering. So it was just sort of hit or miss whether the screen was administered to everybody. So I don't know if that counts because we're not using it for actual assessment, but that's our experience.
But you raised, Melissa, some really important points that have to do about, even if you were using it for a small project to get a, you know, a picture of who's in your system, it's still, whenever you use these tools, how people use them is really important. And, you know, we've learned lessons in the implementation of screening and assessment tools that, you know, the short one-time training is usually insufficient for people to understand what the purpose of the tool is, understand how to use that tool in practice, and also, to be honest with you, how to engage with the client to make sure that the client feels comfortable in answering the questions. All of these tools have, you know, sensitive information that is gathered. So you gave us some good lessons. Thank you, and thanks for sharing with us. Next slide, please. So one of the things that you told us in this exercise is that the tool can be used to identify a population in need. And many of the grantees actually have discussed with us the issues about mental illness and a definition of what that means, also a definition of substance use. So this is critically important and actually a big team building skill that we would ask for you to consider, which is really trying to define what is mental illness and what is substance use. And some grantees also use the tools as a way of trying to identify who should go to what type of service, which is, of course, that referral process is something of great interest to us. So, you know, you all, you know, have experience in using these tools, and we're hoping through this discussion of the Cascade, you'll also learn another way of using the tool as a way of gauging how well your system is performing. Next slide. Okay, so I'm going to do a drive-by of the Cascade model. Just to refresh our memories, it was 6 to 8 weeks ago since our last conversation. If you're like me, I can't remember things from one day to the next. Next slide, Sarah. So we presented this concept of a cascade, which allows us to look at essentially the question of those people who have a particular need, how much are they actually engaging in the treatment system? And I gave you an example from HIV, which is where the Cascade model originated in the 1980s, as a way of helping us look at how well were we managing that disease and how well were we in terms of trying to get people into care who needed care. So we know that the most important thing about HIV is to really get people into viral suppression, because then the person is unlikely to pass along the disease to other people. But in order to do that, people have to progress through the stages of the treatment process in terms of both getting into care, but then also staying in care. So the Cascade provides a visualization of this. Next slide, please. And what we provided for you last time was the process measures that CSG put together that basically allows us to think about different ways that we can measure the, you know, the process by which people are provided access to services and the definitions. So these are resources for you all. Next slide, Sarah. Okay, so today I'm really very pleased to have one of the partners in the juvenile justice trial that was conducted by the National Institute on Drug Abuse. Here I presented for you a copy of how the Cascade model can be adapted for a juvenile justice system where you have multiple agencies involved in the care of youth. So in the traditional juvenile justice system and truant adult system, oftentimes clients are assessed by the justice agencies, but the treatment services are provided by other organizations, which require us to sort of look at the systematic response to trying to actually provide care for people. And the Cascade model provides that visualization, and JJ Trials provides a very good example of what that looks like. Next slide. So because of time constraints, I'm not going to go through this right now, but we also provided with you a resource. We sent you a copy of this article to read, but it also shows you the definitions at each of those steps. But I thought more important than listening about why this technique might be useful, that we should really hear from, people on the ground who have used the model and actually do work in system buildings. And so I invited my colleague, Margaret Cawood, today to join us and describe her experiences in Georgia. So I'm going to turn this over to Margaret to let her talk about the JJ Trials experience and also how they use the Cascade. Before I do that, does anyone have any comments or questions? If so, you could put it in the chat box if you don't want to talk. But that way we can, basically have a dialogue. Again, we're trying to have dialogues here so that you're not just listening, but also having opportunities to process this information.
This is Larissa with San Luis Obispo County in California. I appreciate learning about this and reading the article because I was using the model without knowing it was a thing in my last job in juvenile justice. So it was really interesting to read the article. Thanks.
Oh, great. Thank you. And so now you know it's a thing, right?
Yeah.
And
we called it the funnel.
Oh,
same thing.
Oh, I like the funnel. In justice worlds, we always talk about funnels, the system. So, all right, let's turn this over to Margaret.
Thank you, Faye. Next slide. Okay, and next slide. Okay, as Faye mentioned, Georgia was part of the JJ Trials, which was funded by NIDA, and there were 6 research centers and 6 juvenile justice partners from 6 different states, and each state had multiple sites that participated. And the focus of it was to work on goals to improve linkage between the juvenile justice agencies and the treatment agencies. And what we know with juvenile justice is that we're very policy driven, and we were making decisions based upon inaccurate assumptions, such as if it's written in policy, then of course it's done. If it's written that you make referrals, then of course it's done. However, the data taught us differently here. And what we did with is that the goals that were selected were very pertinent to whatever was what stood out for that particular site. So it was very specific to the site. And we used the multi-agency collaboration team approach, which was the probation officers and treatment providers at that particular community working together through the Cascade to identify the different data points and to extract the data and to see exactly where the children in their community were falling off the radar. And so next slide. So working with data and the data systems, the information systems did present some challenges. What we found out is that not all parts of the Cascade, the definitions were in the specific states' management information systems of juvenile justice, and that juvenile justice and behavioral health had different systems that wouldn't speak or wouldn't share data and were often not compatible. And then we also realized that definitions were different across JJ, across the states, and then across jurisdictions, as well as the definitions for that mental health had. And so that was a process of working through and coming up with consensus on which definitions to use for the process. And then the area for action was defined by what data was available. Thus, if you couldn't measure it, then that wasn't something we could work on, but specifically, what data did you have, and then how could we use that data? So next slide. So just as an example of a starting one, this was a particular county in that it identifies the different phases of identifying how many youth that you had through the intake process, and of those, how many were screened, and then whether they were assessed, and then move it on through the cascade, how many of them processed through that. And then what it helped each particular county and community do is to identify exactly where their gaps were. So next slide. So in showing it all the way through, this shows the different parts where youth were dropping out or where there were problems. And what we found out is that some particular sites found out they were not screening enough of the youth or not screening appropriately. Some sites realized they were not using evidence-based screeners, and then some were not following up with the assessment. So they were seeing different places where the kids were falling off of the process. And this also, using the data like this and working side by side with the treatment provider and the local probation officer, help them walk through some of the inaccurate assumptions that they were making. For example, one particular site, the juvenile justice staff just insisted, well, the problem is with the mental health providers because they keep having staff turnover. So it's their problem why kids are not staying in treatment. But then when you started working through the data, what we saw is that the referral handoff is where they were falling off. So that really had changed the direction of what that particular site needed to do to focus on to have the biggest impact. Next slide. So how did we use the cascade and how is it beneficial? Like I was saying, each county was able to identify specifically what service they needed and exactly what they needed to do differently, whether it was a particular service, whether it was a screening instrument, whether it was changing the assessment process or changing the referral process. Another example was a site that realized that they needed a more formal referral process that required contact from probation to behavioral health and written paperwork or an email back that solidified when the appointment was followed through. So they were able to identify that very specifically, and that allowed them to identify gaps in both the availability and capacity. And that would be one example was on one side, they were not screening many, but then they realized the reason they weren't screening many is because they only had one person trained to be a screener. So actually increasing the number of trained screeners actually increased the number of kids that were screened, and then increased the numbers all the way through. And then it also helped them walk through and talk through with their treatment providers about capacity, that where were their waiting lists, what were the reasons that kids were not being linked to services quickly, and then were not being engaged in the services. And then most importantly, it accounted for the accountability of the screening, assessment, and referral process about assuring that it was occurring for all the youth that needed it, and that there was follow-up despite the challenges that both juvenile justice and mental health would have, but that there was some type of formal referral process and accountability. And another example, like in the juvenile justice system, is that in the past, I think a referral would be made, a parent would be given a phone number, and then they would come back in 30 days and tell the juvenile justice probation officer if they went to the appointment. And so if they didn't and there was a problem, then you had a 30-day lap there. And so one site identified that as a reason and a way to immediately put in some accountability of the date of the actual referral, the date it should have occurred, and then verification whether it did or didn't. And then that was developing a more formalized referral process. And then what they found out from the treatment providers is this was very helpful for them because they wanted more, what they wanted to reduce their no-shows and wanted to increase their services. And it was challenging when they had so many no-shows. So next slide. So being part of a research collaboration, there were both some challenges with that and some awesome gains with it. First of all, we discovered that academia and justice partnerships were challenged because of the difference between the culture and terminology and even perspectives of understanding research versus practice. And then for the researchers' perspective, they were always pushing us to the ideal and taking as much time as possible to work through it. Whereas what juvenile justice, the practitioners were challenged with is in the field that they had a lot of work to do in a little amount of time, had many time frames, and they needed to work very, very fast. And not all of the ideal recommendations were feasible because of the challenges that juvenile justice had. So it really took some working together to massage that and work through that. Some of the really awesome positives that came out of it is that behavioral health and juvenile justice staff were exposed to tools that they had not had the opportunity to use before, such as data-driven decision-making and goal achievement, implementation science, and using data for measuring outcomes. And this really, it was really encouraging to the juvenile justice practitioners because they realized they were finally seeing results. And when they were able to see that, they felt like that they were more effective and that they could be using their time and their energy where they could get the most impact. So those are training tools that we don't usually think about giving probation officers training in. And then the other is around collaboration and facilitation. that training and the use of that was very, very helpful. And those are skill sets that we don't necessarily recruit or train for. However, the relationship building was just very, very powerful. And the recognition that the relationship and identifying the challenges that you had and addressing them as a team was the most important thing that they were able to achieve there. So in summary, that was our experience. It was a very positive experience. Some of the sites indicated that they were going to continue using the framework of the Cascade and the data-driven decision making and use that in other areas too. So thank you. Faye?
Thank you, Margaret. So Margaret, I did have a question though. In the counties in Georgia where you use the Cascade, was the Cascade used at all to help have a discussion about how resources are allocated, or what were some of the needs?
Oh, absolutely. Yes, absolutely. Absolutely. And it would be such as recognizing whether you had enough treatment providers and whether they had the capacity, and then the availability and the staffing and all of that. And actually there were some of the solutions actually came around the partnership of that. For one example, one probation office actually gave a treatment provider an office in their office so that they could actually do the screening and assessments right there on site. So it helped identify the gaps and actually gave the behavioral health partners data to turn around and say to the state or their funders, we need another position, we need more services in this particular area because we have X number of referrals that we're unable to meet in a timely manner. Good question.
Good. There was another question posted for you. So there was, the term data-driven decision-making is used a lot. And I know in JJ trials, we had a specific definition, but do you want to describe what that meant to you, the data-driven decision-making?
Sure, and I think it was easier to explain and was most helpful for our probation staff because we realized we were making decisions. We were making agency decisions, practice decisions based upon assumptions, which were oftentimes was outdated or inaccurate information, where when we actually made it on the data, then we would find out it was a different situation and that if we put our energies in a different direction, we were going to get a better impact. So it is thinking, and when you think about it, it's thinking about however you make any decision, how can it be the most informed decision, and making that most informed decision then would most likely give you the better outcomes.
Mm-hmm. Excellent. Thank you. Are there other questions for Margaret before we move forward? Okay, hearing none. So this part of the presentation is really about building your own cascade. And, I'm going to prod people to talk about their systems as I work through this particular function, but really we broke this down step by step so that you could think about how you could do this with the data that you have in your own jurisdiction. Okay, so step one, next slide, please. Okay, so step one, now everyone has just told us that they have screening tools put in place, right? We already have a list, there's a variety, but there's a list. So one of the things, and this is, what Margaret talked about was really important, is these research collaborations. You all have partners, you have partner other agencies. So the question is, how do you define your key terms? And where is the data coming from? So the question about intake and screening has to do with how many individuals are being screened through an intake process, and that could be at the police, it could be in jail, it could be on probation, it could be at a treatment agency, and whether or not you're able to get that information from more than one source in a particular county. So here, the most important part is to come up with a standard definition of eligibility to be considered for services based upon either having a substance use and or a mental health issues. But here, the instrument you use is really important because it can be the source by which you identify who might have an issue. So can I ask anyone to tell us whether they've been able to use their intake and screening tools to identify the area of need? Can you go to the next slide, please? Okay, so this graph shows us the need issue, and we have this identified as the juvenile community supervision. But how many people are using their screening instruments as a way of identifying who in your systems need care, different types of care? So I have this list of people as participants. There's 15 of us on this call. And I could just pick a name, or if someone wants to talk about how they use their intake. All right, I'm going to pick Charity.
Hi. Well, I was thinking about it because we are, and I'm from Chatham County, Georgia. So yay, Georgia.
Yay.
Oh, and I didn't even know that.
I'm just down
Thank
the
you.
road. I'm practically on the same road as our juvenile here, but I'm actually at the adult county jail.
Okay.
We are currently in the beginning process of looking at a validated screening tool. But as I was kind of thinking about what we do have an intake process that the nurses take at the booking of individuals coming into the county jail. And then through that intake process, there is a referral to the mental health providers that we have here within the jail. And then they go, once they're in the housing, they are seen by the mental health provider. So that's really kind of where we're at right now. And when it comes to referral, we do have a substance abuse program within the jail. However, that is a voluntary thing right now. So the LPCs can recommend it to the individual, but they have to sign up on their own.
Mm-hmm. But at least you're able to identify a need area, right?
Yes. So in their the health database, because it's separate from the actual jail, we can pull data to see who has been diagnosed with substance abuse and mental health, and that's kind of what we're working through right now.
Uh-huh. So, so you gave us an example, which is good, you know, and also we didn't get into this, but the whole issue about referring people. So, you know, a lot of times systems have volunteers, you know, because of how the process works. Other times the referrals or more mandated referrals. And you can see differences in your system depending upon which process works best. And of course, you know, you have to think about what's the advantage of the voluntold sort of way, or, you know, the referral mechanism as Charity was talking about. Can you go to the next slide? I'm going to go skip. Okay. Move on to the next one. Sorry. I think because I want to talk about referrals, because referrals are actually probably one of the more complicated aspects, those handoffs from one agency to the next. Of course, the question here about referrals is, how do we define a referral? Is a referral actually have to do with when, you know, we're recommending to someone services, or we're actually identifying that someone has a need that they should have services? And then the question is whether we're just focusing in on within agency transitions or outside agency transitions, like Margaret was talking about. So what's the referral process that people use? Well, let's see. We have Nick here. Nick, do you want to talk about the referral process in your agency?
Hi, can you hear me?
Yes.
Hi, yeah, I'm Nick Haganey from Fulton County, Georgia.
Oh, also from Georgia.
Yes.
I didn't know that. Go ahead.
Yeah, so I can't 100% speak to the referral process. I know that we at Fulton County Jail, about like 85% of intake receives like a mental health screening. And those screenings are done by the Department of Behavioral Health and Developmental Disabilities, DBHDD. And so they, you know, they have these records of positive screenings, and then they handle like referrals to services, but I don't know exactly how their process works.
So that's not that uncommon, because the handoff procedures, to be honest, are like a mystery, right? And actually in our disciplines, this is one of the reasons why the cascades are so useful, is because they can help us identify, you know, this question about what is it that we're actually doing here? How much of this is actually occurring? So I know, Margaret, you mentioned that, you know, referral was an issue in a few of the sites that were part of JJ trials. Do you want to elaborate on that, like what we learned about referrals and what those handoffs look like?
Sure. And I think that from site to site, actually, the problems with them were different. Some referrals were just giving the parent a phone number. Some referrals, some of the issues had to do with the lack of knowing or communication with the treatment provider, and then the lack of follow-up for it. So for each site, there were different reasons and different challenges around the referral process. And that's where actually knowing the numbers and looking at the data help that particular site determine. I apologize, can y'all hear my train? This train never comes by this time of day. I apologize. Only in Georgia. But yeah, and because you mentioned DBHDD, and I know we have challenges with working with them around around referral process, and oftentimes when you'll hear back and say, oh yeah, we have that service. However, when you actually start tracking and start tracking the cases, then you find out, well, they may have the service, but there's not availability, or it's not anywhere within the 20-mile radius of this particular family who doesn't have a car, or that they're on a waiting list, or they were given an appointment 2 months out. So it's digging down into the details of what is the issue. I mean, what are the issues with the referral process, or on the flip side, where is the referral process working really well, and why? So does that help, Faye?
Yeah, I mean, I think, you know, and Nick, I didn't mean to put you on the spot, so I apologize, but
No
I think it's such an important area that is sort of never talked much about. Turn to the next slide, please. So one of the things, whoops. Yeah, so if you could see here, like in this example from JJ trials, you know, this hypothetical examples, you know, referrals are very difficult processes because you're really, you know, moving people out of one unit to another. And I don't think it matters whether it's within an agency or across agencies. There's still a process because you have different units that have different criteria and different ways of doing business. But Margaret was talking about, and I use the term, there are passive referral processes and active referral processes. So your passive processes are basically saying to someone, oh, go find some drug treatment services, or, you know, you might need some help, go to the community health agency. Or, you know, if you don't have transportation, they might be able to give you help. Active referral processes are actually where the case manager, the person sits down, they make an appointment on the phone, you know, they may even go with that person to the assessor or to the other agency as a way of really basically being a bridge. Now, those active referral processes obviously they take more time and resources, but you're basically engaging the client in a process in which they know that this is important for the agency itself. So you can see this is not atypical where you have a big drop off on who needs care and who actually gets referred to care. So I think, some of you may want to go back to your jurisdictions and begin to ask questions about what's happening in the referral process. Can
Faye,
we move
just
forward?
making sure that you're seeing the chat. We actually have a couple of folks who have chatted in a couple of responses as well.
Okay, thank you. David, Johnson, you want to talk a little bit more about your referral processes?
I can, absolutely. We do a great job once they go to jail, and that's the problem we have found. Why do they need to go to jail? That's been the big question. But once they get there, much like spoke earlier, we have a homegrown system, medical team assesses them for substance use and mental health, and we have a central screening team, first appearance team that comes in and looks for various specialty courts, drug court, mental health court, et cetera, that they may qualify for. And we have internal, the jail has their own licensed clinicians as well as a psychiatrist, and we contract out to Meridian Behavioral for additional referrals. So that part of the system we pretty much have down. I think we do very, very well. From what I understand and what I've seen, the biggest loss is we screen you, we connect you, we refer you, or we give you an assessment, a referral, and then once they leave jail, whether they have in-reach or not, we seem to lose them. It's the idea of getting out of jail and then having to go to the next place. There's numerous barriers there, whether it be financial, transportation, et cetera, et cetera. One of the biggest things that we were requested to do is develop a warm handoff. So we're waiting on our award decision, but we have 2 peer specialists designed to in-reach, go to court with them, basically walk them to Meridian or wherever the facility is, and do all of that active referral that you were just talking about.
Can I ask a question of following up with that about how, David, how were you able to grab who the particular people are or how were you able to figure out who the particular people are? So like what we're noticing is people get bonded out over the weekend or something, or, within a certain amount of time, we're not aware that they are getting, so how in your system are you able to grab that information once they're bonded out and into the community?
A lot of loss there too. If somebody has a cash bond, everyone gets screened at booking. Everyone that walks in, they see both medical and central screening team. But if it's $250 whatever, and they can just walk, they're lost.
Okay, all right.
It's almost impossible now. If in the next stage, we're not the implementation team. We're at just at the assessment, and we develop the next stage. If somebody is screened for mental illness or serious mental illness, our intent is to follow up with them because we have their name and number. Right. We have information. We want to get those connections to the most appropriate entity, whether they have insurance, indigent, et cetera. We have multiple hospitals, including the VA. It's just a matter of that is the loss point right there. That's the black hole.
All right. I thought you had some special thing you were able to grab that from. Okay.
We're working on it, but we don't have the secret yet.
Okay. I look forward to when you get the secret.
But I think having your peer specialists in place, you have helpers, right? Because, some people, just walking in the door is a hard place. And so having someone to walk with is oftentimes really helpful. Mike also talked about having a collaborative referral system. Mike, do you want to let us know, talk a little bit about what that looks like? And also, can you just tell us where you are at?
Can you guys hear me?
Yep. Mm-hmm.
Okay. I'm Mike Torsha. I'm director of Simon County Court Services in Simon County, Illinois, which is the Springfield, Illinois area, the capital of Illinois. Our Justice Mental Health Collaboration Program is actually in the jail. We have pretrial officers that specialized in this deal with the mental health population. She's actually embedded into the jail. Also, we contract with our community mental health provider. They actually have a memorial behavioral health, a mental health professional embedded into the jail. So when somebody is brought into the jail, the first line is the intake officer, the booking officer with the jail. So the jail has their format of asking, intake questions, the general intake information, getting the medical background, getting any mental health background. And then what they will do is if they identify anybody having a mental illness, they'll flag it, and they'll flag it to our pretrial officer. Also embedded in the jail is the jail contracts for medical services out. But they do have medical staff there 24/7, so the referral could actually come from the medical person. Also, they have a licensed clinical social worker that's embedded into the jail, but that person is a possible referral, but that person does not do assessments or screening. That person's utilized for crisis management within the jail, like suicide watches and making sure that if somebody's on medication, that they stay on medication, or if they need to be placed on medication to work through that process. So what happens is that anybody that I mentioned can flag it, but our pretrial officer takes the lead. So when our pretrial officers goes into the jail in the morning, they start talking to all the players and they collaborate together. They actually meet every morning, and that's when they identify. And then if they identify somebody with a potential mental illness going on, what they'll do is they'll go ahead and do the screening and assessment. And then that screening and assessment is actually attached to the bond report that the pretrial officer that specializes in mental health. So that all goes to the court. Then if the court determines that that person needs to be released, then the mental health professional will set up a service plan before that person is released, making sure that they're hooked up to whatever services or resources that they need. That also is a collaboration. So if somebody needs to go from a jail to residential placement or whatever, whoever is available, even the sheriff's office or even our local police department will assist us in like transportation or stuff like that. So that's what I meant when I said it's kind of a collaborative approach in regards to the referrals. Just like David, one of the major gaps that we have is if somebody comes into jail over the weekend, we don't have pretrial services during the weekend. The mental health professional person's not in the jail on the weekends. So if we miss those, we kind of rely on either the public defender's office or the state's attorney's office to say, hey, you might want to take a look at this person. And then we'll start looking at that person to see what we can do for them.
Thank you. So how long has your system been in place?
We actually just started taking cases in January of this year. And then with the COVID situation, it kind of took a little bit of wind out of our sails. So we're starting to gear back up. When we first started, we only had, I think, like 5 people into the program. Now we're up to 15 people that we are actually in the program.
Mm-hmm.
So, I mean, we're hoping to continue to grow, but the COVID situation kind of shut everything down. The court system kind of shut down. And now we're struggling now with our county jail kind of being on lockdown because they had 3 correctional officers that were positive. So no inmates yet, so that's good.
Yeah. Well, COVID has made you know, all of this challenging, but thank you. Appreciate it. And then we have also Melissa Toll, who also wanted to talk about their referral process. So Melissa, can you tell us about the process you have in Douglas County, Oregon?
Sure, and that's our JMHCP program is a mobile crisis program, and so we have 2 counselors that respond alongside law enforcement countywide, 7 days a week, 12 hours a day. And we're down a counselor now, and then COVID slowed things down a little bit for us as well. But that's one of our projects because they are doing some referrals within agency, but we don't have a great way of tracking that right now. The good thing is that the nonprofit that does the mobile crisis is our community mental health program and also our treatment provider. So they're doing referrals to themselves essentially. So it should be easy to track once we get that in place. And yeah, and so I know that they're being referred. I think right now they have a follow-up phone call the next day for people who have had mobile crisis contact and were referred to services, but we'd like to get something more formal in place where we can track it and kind of measure outcomes. We're also trying to get data that will show program impacts, and so we can make the case for sustainability after the grant. So right now, I would say our data is not extremely strong, but we're working with the data analyst to look at things like that and tracking referrals and possibly through the Cascade model. So this is really helpful.
Good. Thank you. Let's see. Oh, we have someone else. I think it's a Lauren Harain, and I apologize if I mispronounced your last name or your first name. But can you wanted to talk about how people are being referred in your county? Can you let us know where you're at? I think she is muted, or he is muted.
And I think that you're looking for Larissa from San Luis Obispo. Not to put you on the spot, Larissa, but I believe that's who popped in there in the chat box.
Can you hear me?
Sure
Yes.
can.
Oh, okay. Sorry. Yeah. So yeah, I had to drop off the video because my phone was dying. But anyway, here I am. Yeah, so one thing that I've been struggling at, and I'm a little new to my position here, is just to get my arms around how well we're doing with referrals. We have multiple different programs which would serve the population, and they all have kind of different entry points. Some are court entry points, some are jail entry points, and that really adds some complexity to figuring out, you know, are there any people that we're missing? Because none of they're all actually delivered in some fashion by our behavioral health department, but they're really hard to get data from. So it's just been difficult to kind of figure out if there are gaps or not. I actually think we probably are serving most of the population that has SMI in one way or another, but it's so hard to know. And then again, you mentioned, Faye, that the defining what a referral means, that came up, which was new to me because I was in juvenile justice. We had a very set process that was all controlled by probation and easy to manage, but this is a little bit more complex. So that's been a challenge for us, but we're working on it.
So one thing, since you are working across systems, you might want to consider, I know it's more work, but to do a cascade for each of your different entry points, so that you're able to really look at different rates across the system. And that may just be really helpful for you to be able to think about, you know, what's actually going on in your system. Okay, so let's talk about the next item on the cascade. And that has to do with, can you move the slide, Sarah? Thank you. That has to do with initiated treatment. So referral is great, but as you all have talked about, you know, the harder part is getting people in the front door of treatment are starting. And typically we don't often understand what some of those barriers are. But one barrier might be the eligibility criteria that an agency uses. Another barrier might be understanding what initiation actually means, because a lot of treatment a lot of treatment agencies actually do an assessment first, and then they'll decide whether or not someone should be engaged in treatment. And therefore, that first visit doesn't really count. So typically, the real issue with going from referral to treatment is really this issue about trying to understand, how long does it take? Because if you really want someone who's got a referral and they're showing up 3 months later doesn't necessarily mean that there's a connection between that referral and the actual initiation into treatment. So we like to think from a research perspective, and again, as Margaret pointed out, there are differences in different disciplines, but researchers tend to think about initiation as occurring within 14 days. I've seen some places where they use up to 30 days. But this is able to basically look at, of the people that are in need, that get a referral, how many show up at the front door of the treatment agency. And part of some of the data decision making that a number of the counties in the JJ trials did had to do with shortening that period of time. So I don't know, Margaret, I'm going to put you on the spot, but do you remember any of the techniques that people did to deal with the shortening of the time between when a referral occurs and when clients actually show up?
Yes, and actually, Faye, what was kind of a aha moment for the behavioral health providers is they didn't realize that juvenile justice had in policy that a referral had to be made within a certain period of time, and juvenile justice didn't understand treatments, their scheduling and all of that, and some of the strategies that they use to change that. One of them, like the treatment provider actually blocked off a certain number of hours every week that were specific for the JJ referrals to make sure that they got in within a timely manner. However, it was on the juvenile justice probation officers to make sure that they did show up and that they weren't no-shows, because otherwise behavioral health couldn't justify continuing to protect that time. Some of the other strategies were around it being that they had phone contact, and that if the appointment was scheduled for tomorrow, and when they showed up, the treatment provider sent the probation officer an email and said, Margaret Cawood showed up, had her assessment today. And if they didn't show, then they got another email or immediate phone call. So there was some immediate follow-up on when something didn't occur or when it did. So yeah, so in each site that identified that, it's like they had different strategies that actually resolved the problem for them.
Yeah, so I think that's an important lesson, right? Is that really we have to explore the policies, not only of juvenile justice or an adult system, but then also of the treatment agencies. And that can help us look at some of the issues, both in terms of solutions, but also in terms of understanding why you have the different rates that you do. Okay, so the next area, if you could move to the next slide, is engaged in treatment. So showing up is great. Showing up in life is really important. But the real piece is how active are people? people. And so researchers have started to use the term engaged in treatment as a way of looking at how long is the person actually active in treatment. And a lot of effort is really focused on in the first 60 days. So if people are supposed to show up once a week and you're only getting rates of people showing up one time or twice, then you can't really consider that the person is participating in treatment. So here, and this is important for your jurisdiction to think about, is I would really think that you might want to come up with a definition of what does engaged in treatment mean. You know, can it be considered, you know, how many sessions that you're actually going for in a certain period of time? Is engaged in treatment actually relating to other ways in which, you know, people might be active in the treatment process? So this is an important construct because it lets us know whether or not the person is participating. And as we all know, if you don't show up and you don't participate, you're unlikely to get the gains that we hope that will come out of participation in services. Next slide. Successful completion. So how many people, I don't know if we can do a raise hand or a little poll here. How many people have a definition of successful completion of treatment? I ask that question because most times it's usually defined as a length of time, not whether or not the person made any great progress in treatment. And usually that length of time is what's the program period. So this is an area where your team really should spend some time thinking about what does success mean here. I know in a lot of problem-solving courts, success means the person is no longer testing positive, right? That there is, Sarah said we can use reactions or a thumbs up if you have a definition of success. So on the right-hand cable, you'll see the raise hands or thumbs up if you have a definition. But this is an area that's really ripe for a lot of discussions and systems, which tells us whether or not you know, we have an understanding of what does success really mean here. And while we think of this on our lens, it's also important to communicate this with a client. So the client understands what does success look like for that particular person. All right, next slide. Continuum of care. So, you know, we always talk about continuums of care, and this is stepping down. Someone's in one level of services and they move to another level of services, or linking from one type of service like a substance abuse treatment to vocational education. But this is a good mechanism for us to be able to ask the questions, you know, how can you identify, you know, how you can identify your system and how well it's functioning. So this is another handoff procedure, right? Like referrals, equally complicated because it's moving someone from one type of treatment service into something else. And, you know, in many of the Cascade models, we don't quite make it here because the data is usually more difficult to gather. But it is something that I would like you to keep in mind. Sarah, next slide. Okay. So the question that you should ask yourself as, you know, coordinators of these grants is what service sources are available for you for each of the definitions that we've given. And if you have electronic records, how can you best use those electronic records? You know, I think that this is one of the most critical questions, which is, how are you going to get the information to do the cascade? Now, theoretically, it would be great if you had all this information in your own data system. But in fact, you know, that's typically not how things are done. And you could see here in the JJ trials, they broke out the cascade model into what was coming from juvenile justice, what was coming from more transitional, and then what were the contributions coming from behavioral health agencies. Now, you know, Mike Dennis, the mastermind of a lot of data, great guy. You know, he and his team spent a lot of time on basically helping each of the 36 JJ trial jurisdictions connect their data together. So I want to take the last 5 minutes of our this presentation before we open it up to talk about data linking, to give you some ideas of things that you might want to consider to bring back to your group. And before I do that, has anyone had any experience with data linking projects, taking data from one system and moving it and joining to another? Sarah, do you want to move on to the next slide? Okay, so data linking is painful, but it's also very useful. And there's 2 resources that I've provided for you in thinking about this. But what data linking is, it's a process of linking administrative data from one system to another system. And that way you can fill in a lot of gaps that aren't available in your own system. Next slide, Sarah. So this was an example of a jurisdiction in Washington State that actually did a data linking project, and they were able to collect data from demographics, health-related data, school data, family data, crime data, housing, and services, and pull that together so that they could get an individual picture of a particular person. So I think this is a gold mine, right? You have all this information on all these different clients. It's, you know, awesome type of things. You know, no one system can actually do that together. But they actually have developed some ways in which they were able to link all these different databases, because as you can imagine, the biggest issue is that you don't have a common identifier that goes across all these data sets. So you could track whether Faye Taxman is in the service database, whether she has a housing sort of issue, whether she has health issues. Usually there's not a common identifier, and that's the biggest issue with data linking processes. Next slide, please. You know, Washington State was able to really come up with a big picture way in which they could integrate the data systems by using some common identifiers like gender issues, date of birth issues, you know, some location issues. They came up with a series of algorithms. This is all detailed in those 2 little resources I gave to you. But I wanted you to basically understand that this is possible. And there's a movement afoot now in the field in a lot of states for these data linkings now to become part of an initiative at the state so that they could actually see what's actually going on across resources within a state. Like in the state of Virginia right now, they just passed a state law a couple years ago, and they have a whole data linkage team that's taking information from the Department of Corrections, from Health and Human Services, from social welfare, from education, to look at the trajectories of people and what you know, who's involved in all these different multiple systems. Next slide. So the process here is basically requires the skill sets that all of you bring to the table. And that skill set is the ability to coordinate and create an environment in which you could actually do these type of data linkages. And that environment means that you have to build a good trusting relationship across parties, that you have to maintain analytical data systems that allow for sharing, that you have to establish kind of a governance structure of who's going to use what. And then you need the expertise of people in your system to be able to actually do these sort of functions. So, you know, I wanted to mention this because to do a good cascade, you know, doing a cascade, you could do it the first time and that's really beneficial. But the second time, you know, you want to be able to produce these numbers. And the best way to do it is to have a way in which your systems can, and I'm talking here systems more like your management information systems or your databases can talk to each other. So this is, you know, a very important avenue. We have a couple chats here of people who have some experience. So I'm going to actually ask Nick. Nick says that he has some experience with a probabilistic data linking in his Fulton County Jail project. Nick, do you want to share that with us?
Yeah, sure. And actually, to address David's comment in the chat, we are also exploring Open Lattice to do our data integration. We've considered trying to do it with the in-house Socrata platform because the county already has a contract with them, but Open Lattice just has so many ready-made software solutions to like so many of these problems that it seems much more efficient for us as a county to go with that rather than trying to build out our own with Socrata's help. I personally have done some like smaller scale data matching with like probabilistic matching methods to just kind of get a gauge on the homeless population in the jail. So there's plenty of literature and some like ready-made software that can do a lot of that matching. But I don't have too much more than that to add.
Yeah, there is a lot of software, and obviously I myself don't have the skills to do this, but you know, there's a lot of really exciting work to be done here. David Johnson, do you also want to add, since you talked about, you know, exploring this one platform, Open Lattice, which I'm unfamiliar with, but I'm eager to learn about?
So we actually had a demonstration with them a couple weeks ago with some of our county leadership, and we are thinking if they can do half of what they're promising, we're very seriously jumping on that. They have everything from police level safety, like don't talk about his dead mother or the dog type of notes in there, to a judge's dashboard that says this individual has X number of Baker Acts or whatever. They say it can connect to virtually anything. HMIS, first appearance, but primarily for us, it would give us a clearer picture and address that lack of identifier. We initially jumped on this one thinking we were just going to follow them from 911 to completion of treatment, and clearly very early figured out that was not going to happen. So Open Lattice is one of the ways that we're considering being able to follow those episodes.
Wow, it looks like Open Lattice has quite a bit of people on the JMHCP grants. We have Melissa and Charity, and Sarah indicates that quite a few people are using Open Lattice. I think it's something I'm going to go have to check out myself.
Faye, just to add to that, so through our high utilizer learning community, with that partnership, we're developing a series of briefs, and one of them will be about what to ask vendors. And then, you know, some of the vendors, there's a lot of similar vendors out there, and our partner on that at I Just Institute, they came up with a list of 50 different vendors. And in looking at that, there were vendors that I hadn't heard of, and I know of vendors that weren't on that list. So just to give people a sense for how many vendors are in this space right now, there's a lot. We do have some grantees who are using Open Lattice. There's other similar platforms that people are looking into as well. We have grantees who have also built their own systems through local county governments as well.
Yeah, I mean, the benefit of linking systems, you know, obviously the high utilizers gives us a vision that, you know, at least we'll be able to identify people that are, you know, frequently involved in multiple systems. But the benefits are actually even greater than that. Like the cascades can be done, right? And we could look at different disorders also besides one disorder. There's also the potential, I mean, you know, a lot of agencies have sort of legacy management information system, and, you know, moving towards some of these other platforms as a way of actually growing out your systems. You know, I highly recommend people consider, and it sounds like Sarah, you guys could, CSG could provide some really good resources to people who are interested in this.
Yep, in the process of developing too, so we hope they're ready relatively soon, but definitely ask your TA coaches about what they're hearing as well. And then folks can also join and on the high utilizer learning community if you want as well. So just keep that in mind too.
Okay. So I'm going to open the floor to any questions and answers, that might have from folks about Cascades. Margaret's here to share her, you know, the experience and sort of, you know, using this within the Georgia Department of Juvenile Justice. Doesn't sound like we have any other questions for today, so I will give you back 2 minutes of your day. Margaret, we want to really thank you for joining us today and sharing information about, you know, what you did as part of JJ Trials, but also your work in Georgia, so we appreciate that. Sarah, I'll turn it back over to you.
Sounds good. So thank you so much to Faye and Margaret. As we said before, the next session is going to be in October, so we'll send out another exercise before then. And if you have any questions, feel free to reach out to your TA coach, reach out to Sheila, who's helping facilitate this learning community. And thank you so much for the active participation today. We're looking forward to discussing this further with you on next session in a couple of months and post-summer, which is flying by. So thanks so much and have a good day.
Thank you, everyone.
Thank
Be
you.
safe.
Thank you so much. Have a good day.
Take care.
Bye.
Thank you.